Hi, good afternoon, everyone. Thank you for joining Advanced Ultrasound Teaching for this week. Absolute pleasure to have Kylie Baker with us again this year. Kylie, thank you again for talking to us. Kylie is an emergency physician. She's an expert in ultrasound for many, many years, published some fantastic papers, and particularly lung ultrasound, an emergency physician with some great knowledge about particularly trauma, and going to talk to us, understand about trauma ultrasound, particularly fast scans. And Kylie, thank you again for taking us through this for some of the candidates about to do the DDU. Thank you.
Absolute pleasure, Sam. It's such a wonderful teaching resource you run here. I'm privileged to be part. This is my conflicts of interest screen, and the biggest conflict now is my granddaughter. It's really hard to button down to work. But let's get into it. I've got a lot of slides because I want to just throw pictures at you so you get used to the pattern recognition. I think everybody's motor control is very good if you can do echocardiography. So I don't really need to talk to you much about how to hold the probe, but I do think you need to know where to look for problems. Now, just remember that the FAST scan started more than 20 years ago, and it was initially compared to diagnostic peritoneal lavage, which was not a high bar. And it was before the age of rapid CT. And last but not least, it was tested in really fit young American patients who got thrown through the windscreens because they didn't have any seatbelt rules. And so we had healthy patients with really high risk trauma. So it came out with great test characteristics. But 20 years down the track, it doesn't measure up. And if you look at this Cochrane systematic review, you'll see it actually argues against the FAST scan in trauma unless you don't have immediate access to a CT. So it still has some benefits, but at the moment it's not recommended in children. It's only recommended in adults if you can't get an easy access to a CT. But I'll point out another caveat. It is still recommended above the diaphragm because the ultrasound for lung and heart is still as good, if not better, than our current tests. So we only use it in special circumstances. So why do you teach it? Why do we still harp on it? Well, the thing is that the off-label indications are probably a lot more use to us than the on-label ones. It's great in my department for ruptured ectopics. We pick up one every 6 to 8 weeks. It's really good to define or assist pluricentesis and paracentesis. It's great for post-surgical complications. And we also use it in a sort of a risk stratification of low-risk trauma patients. So in the old days, you would do serial abdominal exams. Now we do serial fasts, and we do pick up something unexpected, perhaps once every 6 to 12 months. But the real reason that I still love fast scanning is it's an introduction to how to see into the abdomen. It shows you where to put the probe if you want to see behind the gas. And with the right upper quadrant, you have to also learn what the liver looks like, what the gallbladder looks like, what the IVC and the right kidney look like. Left upper quadrant introduces you to the spleen, the jejunum, the stomach, the left kidney. And the suprapubic view is wonderful. It can show you so many things: bladder, rectum, uterus, fetus, ileum, colon. You've got to learn, and you do learn as part of the FAST scan, what these should look like. But since this is a trauma talk, we'll get back to trauma. So what views? You have a set number of views. You must get the right upper quadrant. And if you can get the right lung base in the same view, that's extra brownie points. If not, 2 views. Left upper quadrant and left lung base, either together or separately. A suprapubic transverse view and a suprapubic long view. Now, the reason for this is that the lowest points of the pelvis are actually not midline. They're either side of the pelvis, and so you can't just get a single midline view. The right lung at the high point. Now, this is really important to remind you folk in that when you're supine, when your trauma patient is supine, as they're usually supposed to be, you should not be putting your probe in the lung apex to look for your pneumothorax, because the apex of the lung is not the highest point in your supine patient. You actually need it fairly low down on the anterior chest, just next to the sternum. Same for the left. And I'm really not going to spend very much time at all on cardiac, because you guys know that far better than I do in back to front. I think there's one or two cardiac cases at the end if we get that far. So the first view, the right upper quadrant view, in roughly the mid-axillary line, just about the level of the 10th or 11th rib longitudinally, and we're looking for a picture like this. You might have to negotiate with the ribs. The most important thing is that bright serosal interface between the kidney and the liver. And we're looking in this area for the free fluid. Very important to realize that the peritoneum reflects back off the kidney. It doesn't go all the way to the top of the kidney. And you must show the lower pole of the liver and down the lower end of the kidney. Secondly, we look for that tiny little corner there that you're all pretty familiar with, the costophrenic recess, where we're looking for a little bit of hemothorax. The left upper quadrant view is almost the same. However, the distribution of fluid is slightly different due to the peritoneal reflections and the slightly different positioning of the bare area of the spleen. It's also harder to get this on the same picture as the lung base because the spleen is smaller and acts as a smaller window. In this case, oh, and there's a bit of lung there separately because we couldn't get the lung in the same picture. In this particular case, we're looking in this area above the blue line for our free fluid. Now you'll notice we're not expecting to see free fluid at the deep pole of the spleen or at the upper pole of the kidney. Not at all. That's retroperitoneal. Pelvis, again, you've got to know where the fluid is to be expected. The picture on the left is transverse bladder, and we're actually expecting to see the fluid either side, but not directly posterior. On the right, we have the longitudinal suprapubic view, and the peritoneum reflects back sort of in this sort of shape. So we're not expecting to see any free fluid to the right of that blue line. What we are seeing on the left again is actually the area of the seminal vesicles, that is not free fluid, and the rectum. Getting familiar with the rectal gas shadow is actually quite a convenient and useful marker. So that's where we're looking. Well, there's a rectal gas shadow on the right. That's where we're going to go looking for our free fluid above and beyond the blue line, not the red lines. Now lungs, I'm assuming you're pretty good at lungs. In the old days, we used to put the M mode through to show that there was movement below the pleura. That was because it was really expensive to save clips. Nowadays, it's probably better if you see definite sliding just to save the clip rather than the M mode. M mode is sort of fraught with dangers, false negatives and false positives. And of course, our last view is the heart. I'm not going to show you hearts at the moment. So let's just look at the ideal, really obvious case. Young fellow assaulted with a baseball bat. This is the right upper quadrant view. I hope you can see it's quite strongly positive. There is one problem with this view though, and that is the kidney, as you can see, is in transverse. It's nice to get a picture like this because you can see through the ribs, but if it were negative, it would not be considered an adequate picture. You can see the renal hilum there. To have a true negative picture, we need to see that kidney in long, not in transverse. Here's the left upper quadrant. And you can see a little bit of lung on the left. And this again is an inadequate view. The reason this is inadequate is that there's no kidney seen. And what we do see is a sort of furry, indistinct area here. And I want to point this area out to you just at the moment because this is another trap for new players. I'm going to rush through it and not ask questions, I'm sorry, just because I'm wary of time. Now, this area is where the stomach is. And when you see this fuzzy, indistinct area, sometimes filled with fluid, you actually have to fan the beam to find the kidney. I'm going to come back to that later, that stomach. Here's a better view of the spleen and the kidney. And once you can see that interface between spleen and kidney and you have them both on the same view, you know that you're in the right plane. But here, this particular one has something quite abnormal here. That's actually a splenic hematoma. Now, you are not expected to recognize splenic hematomas as part of a fast scan. But I need you to see it, I guess, to differentiate that from stomach. Suprapubic long. Now, this is important because some people occasionally mistake the free fluid for a poorly inflated bladder. On this view here, the bladder is here and the free fluid is above. This particular free fluid is quite worrying because instead of becoming more hypoechoic, darker as it goes down, it's actually becoming less distinct and more grey. And that's a big concern because that's obviously red blood cells precipitating out under gravity. So that's a good marker of blood clot. And here, that same view, but in transverse, we can see sort of the somewhat odd configuration where we have the bladder in the middle and we have the free fluid peeking up over the top or superficially to the bladder, and we actually have the prostate underneath. Because remember, the prostate is another retroperitoneal organ, so we're not expecting to see any free fluid around it. If you look higher on that patient, if you fan up further, this is what you'd see. And again, really worrying because we can see the swirling of the plankton, plankton sign, swirling the red cells. Can I just pause a minute and ask if people can hear me okay? And are the images, the clips running okay?
I can see them beautifully, Kylie, and you're coming through loud and clear this end.
Am I going too fast?
No, it's great.
That's perfect.
Okay. Please interrupt with questions. Okay, so from that particular case, things I want you to take away is that although we talk about free fluid as being black, it's not if it's fresh blood. The cells tend to layer out and sink. I mean, so does pus, but yeah. The bladder is partly retroperitoneal, so you must expect the fluid to reflect away from the bladder. And finally, I want you to keep an eye out for the stomach because it's one of the traps for new players, and fluid in the stomach is mistaken by everyone once in their career as free fluid. So, a couple of bonus spleens. The spleen, you remember, should be a very even echotexture. It should never have sort of layers or heterogeneous or bits of free fluid in it. But again, recognizing a ruptured spleen is not part of the EFAST scan. Spleen should be about the same size as the kidney, by the by. So here's the other end of the spectrum. This is a young man with right upper quadrant pain. He's been assaulted 3 days before with lots of kicks and punches to his abdomen. He's had worsening abdominal pain, especially the right upper quadrant overnight, but he's hemodynamically stable during his 4 hours on the ramp. That was the old days. And the abdomen was tense and guarded. 4 hours is considered quick these days. So first, I do tend to start with lungs because lungs are the things that go bad fastest. And they're the things where you have to set treatment in motion. So I would, to preference, start looking for pneumothorax before anything else. So obviously there's sliding in that one. And this is the base, lung base, the same site. Not seeing any fluid at the lung base there. Got that nice sort of reflections off the diaphragm. This is the other side. Now you'll notice that this is better position, this one. You can see that the ribs are actually cartilaginous and the pleural line is sort of continuous under the ribs. So that tells me that I took this picture in the right place or closer to the right place. This is the left lung base. It's often hidden by the curtain of the air, but it was a noble attempt. I think it's one of my trainees' pictures. Now, this is the right upper quadrant. Oh, this is my picture. I remember. I'm the only one to blame. Now, first of all, you notice that the kidney this time is in long. So I definitely have the picture in long. Now, can anyone see the tiniest little V of free fluid to the right of the lower pole of the liver? I've actually turned up the gain on this picture to make it a little more obvious. It's just a tiny pointed hat of fluid. Scary, isn't it, that it's so minor? If we go to the left upper quadrant, oh, no, this is another view of it, that tiny pocket of fluid just at the lower pole of the liver there is outlining the bit of gas in the bowel. Okay, this is his left upper quadrant. And again, I'm not even sure you can see any free fluid up there. Just the fact that you can see a tiny bit of peristalsis perhaps outlined makes you a little suspicious. This is suprapubic. Incredible. Oh, no, sorry, subcostal heart. Whoops. I got distracted by his rectus abdominis. This is the suprapubic view. And what we have there is a very sort of deflated bladder in the middle, probably seminal vesicles directly underneath. That is not free fluid. But look up here, we've got a tiny pocket of fluid up to the right. Our screen right, that is, his left. And in longitudinal, all we can see is this tiny little bit, possibly fluid outlining here with the bladder to the screen right. And another view, you can just see that teensy pocket of fluid a little bit better. Now, please don't panic. I've got to say this is about the most subtle you would ever be expected to find. This was a chap who'd actually ruptured his gallbladder, believe it or not. And that was actually bile that had tracked down. So you would be, I think, forgiven for missing that free fluid. It's tiny, but it is a positive scan, and that's where you have to look for the smallest bits of fluid. Okay, this one I'm hoping you'll be more familiar with, but let's go through some of the finer points. This is a young chap who walked in after a car accident. He was the driver of a single vehicle, hit a tree, he was seat belted, he got out, he went home, he had a shower, he still had a sore chest, so a little bit sort of take a breath in, so he came back to the ED. The nurse at triage just gave him an x-ray form and told him to go around to x-ray. This was his x-ray that he brought back, and someone sort of diverted him into resus at this point in time. Have a quick look and think to yourselves how you would report that chest x-ray, what you'd expect to see with your lung ultrasound, and see if it matches with the pictures that we get. So we're only going to look, I think, at the right lung. Now, just a warning, when you see someone using a curvy linear probe, you expect the patient's head to be to your screen left. I know with echocardiography, Sam, I reversed all my pictures for the World Congress of Echo, and then you came and gave me other orientation. Anyway, but you folk tend to put the patient's head to the screen right, and that's perfectly acceptable. Just stick with one or the other, I think. And we tend to get about 4 views. Obviously, we don't want to roll a trauma patient, but these 4 views help you to size or estimate the size of whatever you're dealing with. On the left, if you imagine these were all sliding pictures, the heart will be snuggled up in there, the sort of lower left anterior. I often do the axillary picture without a rib space, so that what that means is each of my pictures has a slightly different look to it. And if I forget to label my pictures, I can make a very good guess as to which pictures they are by the way I've arranged them. Let's look at the other side, however, the side that's sore. That's the apex of the lung. And I admit we've got him lying down by this point in time. That is region 2 probably a little bit laterally. This is region 3, so we're around in the mid-axillary line. Very typical picture. And this is region 4, the costophrenic region, the lowest point we can get. And this is where we're really looking for fluid. Okay, I want you to picture in your mind what you think his CT will look like. Do we have time to send him for CT, do you think? Or should we be putting a hole in his chest right now? Obviously, he's walked in after having had a shower, so we don't have to do an immediate finger thoracotomy. But what we do have time is, or what we can do just to be quite sure, is to go searching for a lung point. And you start from the dry area where there's no sliding at all. It's good if you can use a linear probe because that'll show you the pleura more closely. Ignore the fact that the lung surface is going up and down. That's respiratory heave. That's got nothing to do with sliding. Next picture, I think on the screen right, I can't see it because it's under all my pictures. Can't even see that. Ben, what's on my screen right?
You've got a nice shot of some lung sliding there. I'm suspecting it's near the base with yes. Some comets coming off the pleura.
Yeah, and so this is the middle. This is between the one on the left and the one on the right. There will be a lung point. And if you just slide around a single rib space, you can find the lung point. But I must admit, it's hard work and it looks really good for the medical students, but I'm not sure exactly how much it adds. And this is his picture. And I hope that you all realize that he had a pneumothorax at least out to sort of the anterior axillary line. And you saw all those B lines, which in this particular case indicate a lung contusion. And I hope you also saw the fact that he has no pleural effusion. So the trick and the trap with pneumothorax scanning is that although you can tell the surface area of the free air, you really can't tell the geography of the collapsed lung, whether it's just 2 millimeters below the parietal peritoneum, pleura, or is it 2 centimeters? So you won't know how deep or extensive is the pneumothorax, but you can plot the surface area. And if it is a complete pneumothorax, and this is something you really should do, and I keep forgetting to do, you should immediately go and check the heart function. Because remember, I don't know if it's still a theory, Ben or Sam, you can tell me, but in the old days, we used to think that a tension pneumothorax killed you with mediastinal torsion, twisting the mediastinum such that the IVC couldn't empty into the right heart. Is that still a theory? Can anyone tell me?
Yeah, I mean, I absolutely buy that. I mean, I always thought that it's maybe not just the IVC, but it's kind of filling of the left atrium as well. Anything that slams your mediastinum over is going to cause any form of obstruction. Yeah.
Oh, good. I was glad you said that. This is just another picture to compare a sliding lung on the screen left and pneumothorax on the right. It's a little bit more subtle when you go to a curvilinear probe.
I think we could have some interesting physiology chats about the pressure within the intrapleural space and its effect on the left atrium one day, Sam, and see how true tension pneumothoraces can be.
Yeah, let's just wait for 5 minutes. Yeah, this is, by the way, subcutaneous emphysema. It's a right nuisance. It's obviously a sign that the lung has been punctured somehow, somewhere, and it looks for all the world like a bit of rib shadow or lung, but it's really hard to see through. People talk about milking it out of the way, but I've never been particularly successful with that. And here is another something to recognize. This is the right lung base. The patient's head is to our screen left because it's a curvilinear probe. Ben, what's your interpretation of this one? Trauma patient.
I'm just making my screen a bit brighter. I mean, it looks like you're going to have some small hemothorax in there. I would assume if it's trauma, the way it's doing. You've got pneumothorax there on the screen, right? I can't see the diaphragmatic line, but I'm guessing I'm just seeing some lung coming up and down with a bit of blood probably in there.
Yeah, beautiful. Exactly. That's a hydro point, a hemopneumothorax point. And if you weren't thinking about it, you might think that the free air on the right was moving, because it does sort of have a curtain that moves forwards and back. But that's not breathing. That's the free air being pushed aside by the blood as the patient breathes in. One of the reasons it's quite important to figure out which side of the screen your patient's head is, because if the patient's head was to our screen right, you might think that's normal breathing. But if I say the patient's head is to our screen left, you'll realize it's not normal breathing. And just because it's cardiology, this is, and I'm never quite sure if this was pneumomediastinum or just gas in front of the heart. I don't think it is actual sliding, because the CT had a pneumomediastinum here, but very odd to see air in this particular part of the picture.
Kylie, if you had air in front of the heart, though, wouldn't you not be able to see it behind?
Yeah, it's I think it's to do with beam width, Sam.
So you're getting some of it is nice. So awesome.
Yeah.
Thank you.
Yeah.
I remember seeing a few scans, like I had that same question, Sam, with COVID and the pneumomediastinum were getting there, trying to echo them and just having nothing. This is really interesting, Kylie, these shots.
Yeah, I know. I looked at the CT, I went back and got more pictures. I went and looked at my shots again. It was really weird. Anyway. Now this, we're talking about mediastinal torsion. This is an elderly patient with shortness of breath. It's not a trauma patient, but I wanted to demonstrate it to you. Known lung malignancy. This is actually his left upper lung in longitudinal anteriorly. Not so surprised when you see that chest x-ray. This is his left lower anterior chest. And this is the sort of the left lower quadrant of his lungs. Whoops, I thought it was going to run. So here's his kidney and here's his spleen. And this is actually the diaphragm here. I'll see if I can make it run. There we go. So any comments on that one?
That's really pretty. I think it's great.
No, it's not. It's bloody awful.
Yeah, and there's his IVC, and this is a spontaneously breathing patient, not an intubated patient. And here is his heart. Whoops. Yep. Parasternal long axis is the best that I could do. And yeah, what do you think?
If he was hypotensive, I'd be clinically concerned about tamponade, but I need to always clinically to make that call off that echo.
I think this is my other case of, I think possibly the low volume issue, because he actually had an eventrated diaphragm on the left. It was being pushed down by that terrible tumor. His IVC was big, but the left heart is very small. So I don't know. I didn't follow up what happened to this chap. It was a few years back. But I think I do have one other case of a pneumothorax that was just starting to get the big IVC, small right heart problem. But I'm really sad that I didn't recognize this terribly much at the time. I mean, knew it was bad. Sent him off to the place where they fixed him, but I didn't really realize how bad till I went back and looked at it. Okay, we need to have a child in here because they're also full of issues. This is a 10-year-old boy with a typical handlebar to, I think, right upper quadrant. He's really stoic kid. He's not making a fuss at all. His observations are normal. It's actually sent to our ambulatory care area. The only reason he got a scan was because the trainee was practicing. She's very nicely done our lungs. Nice cartilaginous rib. See the picture on our screen right? Do you reckon that's a lung point?
Yeah, I reckon.
That's actually
probably, yeah.
There's
something coming across the top though.
Sorry?
It looks like there's something else pulsating along the top.
That's the heart. That's where the lung comes in front of the heart.
Sorry, yeah.
So don't mistake this for a lung point. The lung point should be just as white underneath the pneumothorax side as it is underneath the lung side. So if you see sort of a lung edge coming across a dark area, particularly a pulsing one, think to yourself, is this just the lower limit of the lung?
I find it, if you have the ECG there, you can often, that helps you see it during systole. It's sort of in time with that cardiac cycle, right?
Too right. I think you've answered that question. Subcostal, yeah. It's beating, yeah. Okay. Right upper quadrant, again, I've turned up the gain so it shows a bit better on the PowerPoint. Hope you can see that's quite positive. Left upper quadrant. And again, this time we're focusing on the lower pole of the spleen, really important. This is his transverse suprapubic bladder. And as you can see, that this midline is retroperitoneal, and the free fluid is either side of that rectum. So free fluid here and here. And in longitudinal, it looks like this. Now, again, free fluid in the pelvis of children is not abnormal, but free fluid that is particulate, like this is with bladder on the right. See how the fluid on the left is a little bit less black? That's blood, and that is never normal in a kiddie's pelvis, that area there. So children, unfortunately, compensate very well. They crash suddenly at the end. Pelvic free fluid can be normal, and that's one of the reasons that EFAST is pretty much not recommended in children. But particulate free fluid is never normal. And when you're doing your suprapubic use, it can be really easy to mistake the free fluid there for a bladder, particularly in women where they may have a lax pelvic floor postpartum, and the bladder can be very saggy and empty. And you might just briefly look at that picture and think, oh, that's a nice full bladder, whereas it's actually a good pocket of free fluid. This is a young woman with sudden abdominal pain. She's pregnant. Do we need any more pictures than this? I would say she's 8 weeks pregnant. When you see a picture like this is a good sign to push the emergency buzzer and get obstetrics and theatre ready. You don't have to go any further. When you can see this much fluid in the right upper quadrant, there's already a litre or two of blood in the abdomen. Often the free fluid part is what you see in the upper quadrants. This is it in the spleen. But when you get down in the pelvis where we've had bleeding on and off, it actually tends to look very messy, because clot, when it forms, has a similar echo texture to uterus, and it can be very hard to see the difference. When we go in longitudinal, no, we're not going longitudinal yet. There we go. By the way, this area here is a very typical area of the vaginal stripe. It'll be a sort of oval hypoechoic region with a very bright strip of serosal signature in the middle. It's a good landmark, vaginal stripe. Underneath will be the rectal gas shadow. In longitudinal, you can see it looks like nothing on earth. We can see the bladder for sure. We can see that nice vaginal stripe with the rectal gas underneath, but nothing else makes any particular sense. You'll have to trust me if I say that the uterus is actually there with the cervix at the bottom, and everything else that appears to be attached to that is clot. So if you're not careful, you can dreadfully underestimate the amount of bleeding in a pelvis simply because here is not free fluid, here is clotted blood. That jelly bean at the bottom of the screen, by the way, is free fluid deep in the pelvis. It's displacing the rectum, and we can actually see the sacrum deep to it, which is, again, a bad sign of lots of fluid. So clot, it looks like uterus, and when it's adjacent to uterus, it can be very hard to tell one from the other. The sacrum should never be visible. And I'm going to keep moving. This is a young man from a high velocity MBA. He seems intoxicated. He's complaining of severe back pain and he's tachycardic. This is lung number 1. Anyone reckon that's sliding? There's his picture to the right. Sliding or not sliding? That's his right lung. We'll have a close look at that. This is why M mode is so hard. Is that movement under the pleura or does it stretch above? Anyway, here's his right lower quadrant picture. Any comments what's visible here?
An effusion at the bottom by the look of it.
Yep. Anything else?
Maybe a little bit of intra-abdominal free fluid, but underneath the liver.
Yeah, now under here, you don't get free fluid. That's where the IVC comes through. That's near the bare area of the liver. What about this bit up here? What do you reckon that looks like?
Air.
Air, exactly.
Rupture to viscous.
Yes, this is his other side. This is his left side. And obviously, what do you call that sign on his left side? See how I've got
sandy beaches and seashores and all those things.
And even more than that, that's lung pulse. Can you see how there's a sort of a regular rhythm to it?
Nice.
So that just, it proves that you've got expanded lung because the cardiac pulsation can't be transmitted across just air. It has to be transmitted across intact lung. Now here is, I've been, saving this one up for you. Remember I said at the beginning that fluid in the stomach that sits posterior to the spleen looks for all the world like free fluid, looks dreadful, but in this case it's not. That's simply fluid in the stomach. But his right upper quadrant, again, not the classic view. That's gallbladder in the middle. You can see a bit of liver here, but you can certainly see there's fluid either side of it. But here down on the right, we've got fluid at the lower pole of the kidney. It's sort of the Morrison's pouch swings in and out, but if you can see the bit of fluid at the lower pole of the kidney. Anyone want to tell me where that fluid is?
That'd be retroperitoneal, wouldn't it?
Exactly. And really important that you recognize this. This is not free fluid in this particular spot. Now, this was a chap who I think, he got a liver hematoma, ruptured a viscous with the free air, but he also had a big retroperitoneal hematoma. And understanding, it's really important to understand that there are, I think, 4 layers of peritoneum in the abdomen, and where you see the fluid depends on which layers have been separated. I love this picture from Radiopedia, I think. If we were looking longitudinally from the Morrison's pouch view, our intra-abdominal free fluid sits like this. Remember I said the back of the liver is a bare area? It never tracks around there. Fluid that's directly from the kidney, such as a ruptured hydronephrosis or a ruptured cyst, sits around the kidney like this, in this shape. But fluid that is tracked from one of the great vessels or even from the pancreas, typically an abdominal aortic aneurysm rupture, has this pattern. It can sit above the kidney and below the kidney. It's a sort of spindle shape. That's what this chap's fluid looked like, wasn't it? So it's really important that you realize that you will see fluid in places fluid shouldn't be. But the bottom 2, they're not considered a positive fast either, although they are very, very significant. This is just another picture of fluid at the lower pole of the kidney. I think this one here was actually just a ruptured uroma. It tends to be a lot less irritating than blood or retroperitoneal fluid. Can you see that tiny spot there? It sits right on the iliopsoas muscle and follows the contour.
Can you show me again, Connie?
Just here. Is my little pointer showing?
Yeah. It's just me. Sorry, I missed it.
Okay. So Lung pulse, as I showed you, excludes a pneumothorax at that point. Doesn't necessarily mean the lung's ventilated, but it does mean the lung is expanded. It's important to understand that there is a retroperitoneal component, and you can rupture ascending colon and you'll get fluid in that same compartment, or descending colon. Be able to recognize free gas in the abdomen. It's a bit harder than the lung, but it has the very, very similar appearance. And here's another picture of free gas in the abdomen. See on the middle of the screen there? I always like to look for it over the top of the liver, because that's one of the places where you can guarantee gas is not meant to be. And when you push down on it, it should move out of the way, because it will stay at the highest point that it can find. Now, real trauma case. Oh no, this one's not the trauma case. It's a different one, and I think it's important to illustrate a couple of things. At least I don't think it was trauma. We never really got the story. This is a 55-year-old patient with a week of increasing chest pain. He's got a history of hypertension and intravenous drug use, which is mostly stimulants. And he called the ambulance, and they said that he was vague and febrile. And as they were walking him off to the ambulance, he nearly fell over. So it was a bit pre-syncopal. They also noted he had pitting edema to both knees, but it was certainly worse on the right. Now, I want you to take a minute and think, what's your differential diagnosis? It's a really wide differential, and we'll work on it, and think how you're going to approach this patient. Now, ED being as chaotic as it was, he ended up getting his lung scanned before he got his chest X-ray. I don't think he was lying down, because he was not a trauma patient. So imagine he's semi-reclined, and we're getting a picture at the right apex and the left apex. Right lower anterior looks pretty nice. Left lower anterior looks a bit strange. Right axilla, mid-axillary line, left axilla. Definitely exciting. I saw that and thought, yes, we've got a live one. Right posterolateral, pristine. That's what a picture should look like. Left posterolateral, rubbing my hands with glee, thinking, yes, I've made the diagnosis before we even got the chest X-ray. I was so proud of myself. Then chest X-ray comes along, and we thought, oh yeah, okay. Now I won't say exactly what we thought about that, but the med-reg came to one glance over our shoulder and said, yep, that looks like left lower lobe pneumonia. Put him on some antibiotics and put him up on the ward in surgery. And I've got to say, we didn't. Anyone like to suggest why we didn't take the easy path? What have you seen so far that worries you? Well, while you're thinking, I'll show you his IVC, which is off to the left because it's a curvilinear probe. I'll show you his aorta in the middle there in transverse. Crappy view, no apologies. There's his subcostal heart. It's very hard to get cardiac pictures. I was actually very proud that I even saw his heart. In fact, the very best picture I got was this one, an apical 3-chamber view. Anyone want to commit yet? Is what's going on with this patient? Any guesses will be welcomed wholeheartedly. Is this what you normally expect to see in a pneumonia?
No.
No, what's wrong with it?
Afraid, Kylie.
Sorry?
I'm struggling a little bit. You're going to have to help me with this one.
I mean, that's great. That's got no color flow in the lung. You mean it's power Doppler, so you should see something.
Yeah.
But there's nothing there suggesting that it's got no flow. So he's got potentially a massive PE, and he's infarcted off that chunk of lung. His heart seemed to be going like the clappers, a swollen leg. He's got an effusion that looks fairly simple. And I think that the color Doppler, the power Doppler signal getting in that fluid is probably just flow rather than anything else.
Yeah, that is artifactual movement at the edges.
Yeah.
But what's the other thing that's really tricky about this, and Ben, I got to say, I missed this as well. I only went back and put the color flow on afterwards. There's no air bronchograms in here either.
No, there's nothing, but it's still fairly inflated. And you have to think, is it actually lung?
Ben, leave it. You know what? I was allowed to. I showed this to a couple of friends across the big pond, and both of them, who are from America, said immediately, "Oh, that's a clot." And I thought, what? But you see, the clot has formed a cast of the pleural cavity, and it moves in the free fluid just like lung. And that's why we can't see any flow in it or any air bronchograms. And if you go back and have a look at the
There's
aorta.
something moving funny there, yeah. And
yep.
look, yeah.
The aorta, and then when we go back again to this one, I mean, that aortic root is prominent. I mean, I usually make a good effort to get rid of it in my subcostal view. And then if we go right back to the chest x-ray, look at that aortic knuckle. So just because we were feeling a bit antsy and it didn't quite make sense, we asked for a CTA, and we're actually might have asked for a CT angiogram, looking for a PE. And halfway through the evening, the very distressed radiologist rang us back and said, "You know, he's got a ruptured thoracic aneurysm, don't you?" And we all sort of looked really embarrassed and immediately sent him to another hospital, where he actually did very well. So this is one of the cases that made me sit and try and look at how we tell consolidations in lung. I've just presented this at H&R, and I think I also mentioned it at the World Congress of Echo. But you can virtually rank consolidations by the amount of vascularity that they have. Pneumonia and, unfortunately, atelectasis are hypervascular, although the atelectasis loses volume, whereas the pneumonia tends to maintain volume. Malignancies can be anything. They tend to have peripheral disorganized vasculature, but unfortunately just a few of the primary malignancies will have normal, if not increased vasculature. Now, pulmonary infarcts have stunted vasculature, and if you manage to go in the contrast, Ben, this is what you can really have a look for, pulmonary infarcts. And clot has no blood flow at all. Just contrast it with this one. I'm going to run through this one. This is a chap who ran into a tree. He was febrile, so they thought he had pneumonia, but he seemed to be pretty dry. And so they asked me, would I look at him to see if they could give him more fluids? At this point, he was admitted sort of medically, and they were waiting for him to see the med-reg. And I was trying to tell him, no, you don't need lots of fluids in sepsis. And I was trying to find a reason to tell him not to give fluids. I actually didn't do real well. Going down his right lung, right lung on our left lung on our right. I mean, you've already seen his chest x-ray. It wasn't beautiful. We're sort of expecting to see this consolidation on the right side. This is what they reported as a pneumonia. Nothing on the left. And the right lung base, a little bit crumpled, the tiniest bit of effusion. I thought to myself, yeah, that's a parapneumonic effusion. I totally accept that. But I was still trying to find a reason not to give him extra fluid. This is a closer look at his right lung base. Now, this is a guy, by the way, I skipped quickly because I'm watching the time, who ran into a tree at a low velocity. It was a single vehicle accident, and he was quite hypoxic when they pulled him out, but the ambulance just gave him a bit of fluid and some oxygen, and he came around to sort of full mentation afterwards. He's known to have a cardiomyopathy with a pacemaker in, but he's recovered so well that he's got his own courier business. And I'm still trying to find a reason not to give him fluids. And I'm thinking to myself, yes, I've seen a pneumonia. Yes, I've even seen a little bit of parapneumonic effusion. possibly even a bit of parapneumonic pericardial effusion. Really, I was thinking it was really hard to get pictures because he had a pectus excavatum and he wouldn't lie down. Hope you're starting to get worried. This is his ECG. And his blood pressure's going down further. And his wife came up to me and said, could he have some pain relief? His chest is really sore. And you know, one of those blinding moments at 11 o'clock at night, and you completely do a belly flop and think, oh no. So I put the linear probe directly over the sore part of his sternum. And I think you've seen this picture before. That is not what a sternum is meant to look like. It's not meant to move in the middle. And this little hypoechoic area above it is a fracture hematoma. So of course, this completely upended our diagnostic process. He went from being a pneumonia with a trivial MVA to being an MVA with a trivial pneumonia. And so he went back to the CT with cap in hand and much begging. And the CT report completely turned around from the chest X-ray report, said he had a fractured sternum. They called that lung pulmonary contusion with a retrosternal hematoma. He went to coronary care then as a myocardial contusion. His troponin went up to 12,000 and his blood grew streps. I really don't know which it was. I think it was probably both, because when I did put the color flow over his consolidation, compare this with the other one, it's the whole reason I've got this case on, he's got quite a lot of flow in there. So me personally, I think that was a pneumonia. I think that was not a contusion, but he did have a significant external injury, probably a myocardial contusion, and he did quite well once we treated him properly. So I think I better stop there because it's 3 o'clock. Any questions?
Kylie, thank you very much indeed for that. That was absolutely sensational. Just from the DDU point of view, you know, if questions come up about chest trauma, sort of give us for example, I mean, one of the questions I think that they've had in the past is talk about someone with a blunt contusion to the chest and how ultrasound can help in your sort of diagnosis of that. Would you split that up, that kind of question, into looking at bones, pleura, lungs, cardiac, you know, how would you, and then I guess diaphragm, is that how you'd split up a question like that?
Well, I must say, as an emergency physician, I would split it up into what's going to kill the patient first and what do I have to treat first. So bones, they're not going to kill the patient, but a pneumothorax is. So the first thing I'd be doing would be looking at the lung sliding. And you've actually got to force yourself to look for lung sliding. It's so easy to find the picture and then you think, yeah, got the picture, and move on. So look for lung sliding. The second thing that's going to kill the patient is a hemothorax or torrential bleeding. So I put the probe on the highest spot, then the lowest spot, because you want to get treatment started ASAP in those things. If there is time, then you can certainly look at the bones after that, but the bones really don't add a great deal to your immediate management. Yes, they can be broken. They indicate further trauma, but short of a pneumothorax or a hemothorax, they're not going to make a big change in your immediate management. Now, contusion, as we showed you, is very easy to see. It's very obvious, at least from the first pneumothorax case. And it's often peripheral. So contusion, I don't think it changes what you do for the patient very much, other than it's a really good way of saying there's no pneumothorax. So I guess I would go look for the things that are most urgent, look for lung sliding, look for hemothorax. Then at this point, this is when I'd say look at the heart now and see how it's functioning, because everything you're doing is just gross problems. It's not minor things. You won't have time to go looking for rib fractures unless you're really bored or you're transporting him. They're not going to make a difference. Sorry.
Thank you very, very much indeed. That's a fantastic answer. Were there any other questions anyone had for Kylie? Yeah, Remy.
Sam, I have a question. Hi, Kylie.
Hi.
Basically, you showed one scan of hemopneumothorax, where the air curtain comes over the hemothorax.
Yep.
I was just thinking that the hemothorax is towards the head and the pneumothorax is towards the feet.
Yep.
Was that what the orientation was?
You imagine it's a supine patient. And the other thing to remember is that when you put the probe on the side of a patient, the area closest to the probe is actually the side, not the top. So that picture, we actually had, say, imagine it in is it a coronal plane in the axillary line? And just by tilting the probe a little bit to get it between the ribs, because remember that the ribs are slided are inclined like that. And so your probe, when you put your probe in, is not going to be completely flat. It's going to be tilted like this. I think that's the reason we have air on the odd side. I agree with you. It does look wrong, but it's very, very common that you put your probe on, and then because the rib's in the road, you rotate it, and then you rotate it a bit more, and then you rotate it a bit more. And that's how we end up with those transverse views of the kidney, for example. But again, it's not something you can easily avoid. You just got to understand or remember that the probe won't be a true coronal plane. Does that make sense?
Yeah, thank you. Thank you very much again. These are great talks as always. Fantastic cases in there and just this wealth of experience. Thanks, Kylie. And that's it. We look forward to seeing everyone next week.
If you learned something, hit like and subscribe to our channel for more videos uploaded weekly.
For bite-sized versions, follow us on Twitter @EchoNepean and check out the tutorials.
Or head over to our websites for the latest hands-on courses. Links in the channel banner.
And thanks for watching.